speaker I'm going to introduce. Usually I'm in awe and I'm scared of radiation oncologists per se, because my wife is a radiation oncologist. So it's my pleasure and privilege to welcome Dr. Rakesh Jalali, because we had a discussion on one of the lacuna that we have in our training is approach to CNS tumors, where we are a bit confused. This is none other than Dr. Jalali to tell us about how to approach it in a systematic way, and some of the things can be asked in the exams in theory as well as during discussion, because in the practicals you don't have CNS tumors, so you will have in viva or in discussion as well as in short notes this topic very important. And I'm sure Professor Jalali, the director of Apollo Proton Center, will tell us in the next few minutes.
Thank you, Dr. Rakesh. It's been a great pleasure to spend. I always enjoy talking to young people because that keeps us young to some extent, we hope. So I don't need this, right? Oh, great. I think it's a great opportunity for you to come to these meetings, and we were just discussing with my colleagues as well. I'm a radiation oncologist, as you know, so the Association of Radiation Oncologists of India actually for the last now almost 12 years carries 4 to 5 courses exclusively for postgraduate students. And we change the theme every year, every course. In fact, there is a course coming up very soon next month and in Hyderabad. So I think the Indian Society of Medical and Pediatric Oncology could take the leaf and formalize it rather than several hospitals coming together and trying to invite you, because that would be a great opportunity to discuss. And medical oncology, actually, they don't need any, funds is not an issue, so it's just a matter of organization. So I'll just talk to you in the next few minutes about the CNS tumors. We don't talk too much about CNS tumors in general because they are rare. They comprise only 2% of all the cancers you see. But most of the people are amazed when they come to know that in a very prime age group of between 20 to 40, it is the second leading cause of cancer death in males, fifth leading cause of cancer deaths in females. We also know glioblastoma does remain still one of the most aggressive tumor, not only in the brain, but in any part of the body. And this is the incidences that you see. Glioblastoma, which we will discuss a little bit more in detail in the subsequent slides, does remain a very enigmatic and very challenging tumor. Most of the oncology, one of the major challenges why we don't succeed is metastasis, because you may control the local control, you do surgery, you may do radiation, you may have systemic therapy, but it is the metastasis. And whatever we may say, for the last almost, decades and decades of research and evolution of treatment, metastatic disease in cancer largely is incurable. You do not cure it. It depends upon what you mean by cure. You may extend their survival, you may do some palliation, you may prolong their longevity by 2 or 3 or 4 or 5 years, but largely it remains incurable. And yet, glioblastoma never ever metastasizes. It remains primarily in the local area of the brain. In about 1% of the cases, it may go to the spine and may cause a leptomeningeal spread, especially in children or young people, but largely, and yet the local control, we cannot cure it, as you know. It's a largely incurable cancer, although local control should have been equal to cure. In brain tumors, as perhaps is in any form of oncology, it's not only the improvement in survival, their interval of having a disease-free, but also rehabilitation, quality of life, social functioning, patients-reported outcomes, which are extremely critical to determine the success of the management paradigms that you or you may be doing in your practice. Many years ago, most of my career was in Tata Memorial Hospital, where I started the neuro-oncology practice. So in about 10 years ago, we did a very simple thing. We compared our patient demographic profile with those from the West. Primarily, the data was taken from the SEER database and the Central Brain Tumor Registry of the United States. And we found out that our presentation age-wise was about 10 to 12 years earlier as compared to the Western cohorts. And it was interesting that it was primarily seen in the malignant tumors, not so much in the benign tumors like pituitaries and meningiomas. And one could speculate what could be the causes, and perhaps we can discuss at the end of the presentation. What you must know is that the World Health Organization, the WHO, comes out with these what we call little blue books, which are kind of a Bible for all the neuropathology of brain tumors that we see in our practice. There are only about 130 odd brain tumors. If you want to fail an exam student, you just tell him to list out the number of brain tumors that you have. So till 2007 was the 4th edition, but there was, as a revolution of molecular markers, as is in other sites in the body, I would say after lung, perhaps the second commonest site where it has completely revolutionized the treatment is actually the brain. The insights on molecular pathology and the genetic profiling, which would influence not only the prognosis and treatment, but also literally guides us in our current management and also guides us in our future clinical protocols. So largely 79 to 2007 was based on histology. This is an oligodendroglial tumor. We call it a poultry tumor. After some time you will, whenever you come a slide, it's very readily easy. It has this small round cells, almost like a cell tumor. Also has what is called a classic fried egg appearance. It's almost like you have a fried egg. And it does have a fair amount of angiogenesis, which also means there is a fair amount of vascularity, which can be proven factor 8, and you can see other morphological criteria. And they have this what is called a classic chicken wire mesh or framework. That's why we call it a poultry tumor. In astrocytoma, they do not have a round cell. They may have an occasion, they are largely glial cells, but they do not have so much atypia and they do not have so much mitosis. Whenever you have atypia and mitosis with some amount of central hypointensity like this, even in the pathology, this is called necrosis, or what's called palisading necrosis, is a classic hallmark of a glioblastoma. We do not anymore say glioblastoma multiforme as was the norm. We just call it glioblastoma, but in short, you still call it GBM. So astrocytic tumors are classically divided into 4 grades. Grade 1 is a childhood tumor, it's called pilocytic astrocytoma. I will show you a few slides later. Grade 2 is an astrocytoma. It can have 2 components, astrocytoma or an oligodendroglioma. And then grade 3 can also be an astrocytoma and an oligodendroglioma. And finally is the glioblastoma, which is a grade 4 tumor or grade 4 brain cancer. And this I said, there was an update in 2016, which has again revolutionized the way we treat our patients. And I will show you some examples as well. And this was the first time we incorporated the molecular information into not only in our diagnosis, but also in our prognosis and our treatment paradigm. So incorporating molecular data, as I said, there are astrocytic tumors, oligodendroglial tumors, there is ependymal tumors, choroid plexus tumors. Some of the tumors there was a term called oligoastrocytoma, where on pathology you could see subset of oligodendroglial tumors, but also astrocytic tumors. And the pathologist always used to wonder, and we used to always ask the pathologist, is it oligo, is it astro? Or if it is a mixed tumor, how much more is the oligo component and how much is the astrocytic component in our joint meetings? Because as therapists, we were very keen to have more oligo because they respond better to chemotherapy and radiation, which you will come to know subsequently. But actually now there is no term of oligoastrocytoma. It has been buried. You can never, if some pathology report you see oligoastrocytoma, don't trust it, don't believe it. You have to know whether it is an oligo, whether it is an astrocytoma, and that is a genetic signature rather than a morphological signature. And that I'll show you in the subsequent slides. And in general, they are called now diffuse gliomas. So there is a circumscribed glioma, which is a pilocytic or a PXA or a grade 1 tumor, especially seen in children. In the adult population, what we call diffuse infiltrative gliomas can be an astrocytoma or a oligodendroglioma, grade 2 or grade 3. And I will show you also there is a less distinction between called grade 2 and grade 3. We call them lower grade gliomas rather than low grade gliomas. And finally, the glioblastoma. And you, of course, you can have other tumors like ependymal tumors, choroid plexus, germ cell tumors, pineal tumors, embryonal tumors or medulloblastomas, and a huge chunk of benign tumors like a vestibular schwannoma, pituitary tumors, meningiomas, and so on and so forth. And I have not talked about metastasis. So that's a different subject altogether. What makes brain, before I go to this, what makes brain so fascinating and why neuro-oncology is such a, I've been doing oncology for the last 20 years, what just drives me. And there are 2 or 3 great things in neuro-oncology. One, it has a huge spectrum. You have a breast cancer, or you have a lung cancer, or a prostate cancer, or a head and neck cancer even to some extent. You can tell that there is a particular profile, the age-wise, the sex-wise, which age group it could be. In brain tumors, they can literally start from infants, to young children, to the older child, to the adolescents, to the young adulthood, to the middle age, and to the very late. So you have an entire spectrum literally affecting every single age. As I also showed you, there are only about 130 or 140 types of brain tumors. Breast cancer, well, there can be different types. There can be TNBC, EGF, this HER2. You can do this little bit of molecular now, the luminal type and other types. But in brain tumor, there's a huge plethora. And also, as I said, it has an interesting challenge because it truly represents a multidisciplinary care. Should be in all oncology branches, but perhaps this is the epitome of incorporating every single person into the field to give a proper treatment for these patients. As we discussed, low or lower grade gliomas has been a conundrum for all the neuro-oncologists for the last 30 years. Because we used to have a subset of patients which used to be doing very, very well, and we used to just observe them, even on imaging, sometimes not even operating them. And yet, we had some patients, we thought it was a low-grade glioma on an MRI scan, as well as on a pathology after a surgical section, and boom, after 6 months to a year, it turns out to be what's called a malignant transformation into a higher-grade glioma. Many, many years ago, Ignati he collected the data of 2 very large randomized phase 3 EORTC studies looking at observation versus deferred radiation, observation plus deferred radiation versus immediate radiation, as well as there was another cohort, another group, another trial using the different types of radiation. So he collected the data and found out that if the age is more than 40, if they are crossing the midline, if the tumor is more than 6 centimeter, if it's an astrocytoma rather than oligodendroglioma, and if the patient has a focal neurological deficit, they are worse, they are not so good clinical factors, even if the histology is grade 2. Now imagine that even if the histology, and they are non-enhancing of course, so even if the histology is low grade, but has all the 5 features, the median survival is only 1.3 years. Even if called grade 2 astrocytoma, which is almost like a glioblastoma of 1.3 years. So this is the importance of having clinical factors which really makes a difference in our day-to-day practice. But still, it's kind of still not crystallized completely. They tend to be slowly infiltrated. That is the thing about gliomas, because they are not circumscribed, they are diffusely infiltrated. And the more and more you try to resect, it is very difficult to achieve cures by surgery alone. And one of the things which completely revolutionized for about a few years now, what is called IDH, and IDH is hematological malignancies as well, was the discovery of an isocitrate dehydrogenase mutation, and both it is present on the 132 codon, where arginine is replaced by histidine, and that makes the whole change. It is actually a gliomagenesis gene. It actually initiates the gliomagenesis and is present in about 90% of grade 2 tumors, whether it's an oligo or whether it's an astro. Oligos, actually 100% of oligos are IDH mutant or IDH positive. If you get an oligodendroglioma pathology report and the IDH negative, it cannot be. Either the test is not done correctly or it is not an oligo. You cannot label an oligo unless it is IDH mutant. As the grade increases, unfortunately, the IDH mutation becomes less. So in glioblastoma, which is a grade 4 brain tumor, the incidence of IDH mutation is not more than 10% or so. And even if there are those 10 to 15% in Indian cohort, based on Tata Memorial Hospital data and NIMHANS, we found our incidence was about 15%, slightly higher than the world literature. And these represent what is called a secondary glioblastoma, because glioblastoma has 2 progressions. One, it starts with what is called a primary GBM, which is EGFR dependent, which is P53 is not positive and does not have an IDH mutation, starts de novo mainly in elderly population. In the slightly younger population, it can transform from an erstwhile low or lower grade glioma, and those are the ones they may have small instance of IDH mutant tumors. And because, as I showed you earlier, our age population is slightly younger, median age of GBM is about 50 years as compared to 65 in the US. So we tend to have a younger patient population. We speculate that maybe there is a slightly more lower incidence of IDH mutant GBMs in our cohort of Indian patients. So what it means really is based on two large databases which was published, one in NEJM and one in Nature Genetics, was the TCGA data. TCGA is the Cancer Genome Atlas, many of us must be knowing. Can you guess the first tumor the TCGA profiled in the year 2000?
GBM.
Fantastic, you don't need me anymore. So you know everything. So they collected the data from the grade 2 and grade 3 tumors, and also there was a Japanese cohort, and they found out what is called 3 types of low-grade gliomas. Histologically, peer-reviewed, centrally, it was all the 4 or 5 neuropathologists said, well, it's like a grade 2 or grade 3 tumor. Grade 1 and grade 4 were excluded. And yet they found if the patient has an IDH mutation and a 1p19q co-deletion, which we will come to again in a minute, 1p19q co-deletion was a hallmark, as you probably know, of an oligodendroglioma. So they were oligodendroglial tumors. If they had IDH mutation but were not non-co-deleted, they were astrocytomas. And if they were wild and non-deleted, even if called grade 2, these tumors were not so great. In fact, if you plot the survival, the type 1, which is likely to be an oligodendroglial tumor, had an excellent survival, more than about 75 to 80% long-term in 10 years, while the wild type was closer to a primary glioblastoma cohort, and that is why it made kind of it was so great for all of us. We used to struggle in grade 2, what do we do? And then now if you have this molecular information, it will help you in your practice. And I'll show you a case. So this was a lady, young girl I saw in TMN a few years ago, I think 4 or 5 years ago, and she had a small tumor, but it was completely non-enhancing. In the factors that I showed you, those age, crossing midline, there are 4 or 5 more factors actually. Those were the factors based on their data. But we also know that enhancement is a bad factor. Whenever you have enhancement, it suggests a breakdown of the blood-brain barrier, also suggests a higher grade. So they are non-enhancing tumors. And also Midman index. Midman index, if more than 4 to 5%, shows a proliferation potential of the tumor, and then they don't do so well. So if you had, this was a right side, and right side is a non-eloquent cortex of the brain, relatively safe, frontal lobe, not close to any critical structures, non-enhancing, not really crossing the midline. Well, there's a subtle cross of the midline. Otherwise, the reasonably factors. She was operated upon. This posterior aspect was close to the premotor cortex going towards the functional area. So this was not operated upon, and this was just excised anteriorly, as you can see. This is the residual disease, and she was observed, and it was reasonably, and it was, histopathology was a low-grade astrocytoma. She was not operated in TMA, she was operated in some other institute in the north. So what happened was, after almost only about a year, you can see how increased the tumor is. It had clearly increased, and she was symptomatic. She had mild hemiparesis on the left side. We reoperated on her literally 2 years down the line, and now there was a clear-cut high-grade glioma. So within 2 years, less than 40, not really crossing the midline, less than 6 centimeter, non-enhancing, and yet within 2 years, boom, there was a high-grade glioma transformation. What could be the cause? We did an ATRX. I should also tell you about the ATRX. So ATRX is ataxia telangiectasia gene. So basically, whenever there is an ATRX loss, which means it is a grade 2, grade 3 astrocytoma. Whenever there is an ATRX loss. Whenever ATRX is retained, it is either an oligodendroglial tumor, any grade, depends on the morphology, or a glioblastoma. So remember it. So whenever there is ATRX loss, actually it means grade 3 tumor. P53 was positive, Midman was about 10 to 12%, but IDH was negative, which I showed you earlier. So IDH was negative. IDH is generally done by IHC. It's a very simple test, costs only 4,000 or 5,000 rupees only, and we are bringing it to the rest of the country, and I can show you some slides. But if it is a negative, otherwise in a younger patient, you have to confirm with sequencing. It doesn't need a big sequence, it just needs a Sanger sequencing, which everyone has in most of the labs. So you just do a sequencing because we know which genes to see, but it was sequencing also on, it was negative also on the sequencing. So it was a true blue aggressive low-grade glioma, IDH wild type, yet in a young patient. And these are the case scenarios which will help us in our practice. So if this case would come to me and IDH was negative, I would never ever observe this patient. You have to be aggressive in these patients. This is what you learn from this case. There has been always a dilemma how much really surgery should be done, and there has been a tremendous evolution of neurosurgery over a period of time. And there is no randomized trial. It's very difficult to do randomized trials in surgery and radiation local therapies as you are accustomed to for systemic therapies. This is the best data about 6 years ago. It is a Norwegian study where 2 centers were there. It's not a big country, it's a relatively small country. What they did was, one center was doing just waitful watching in low-grade gliomas, and one center was operating upon them, whatever cases they come. And this was published in JAMA actually. And they found out that the patients who had undergone resection, the survival was significantly superior as compared to the patients who you just watch. And that is an evidence for the evidence of extent of resection. Just a minute on surgery. Surgery, as I said, there are 3 or 4 revolutions which have taken place in surgery. Number one, which is called neuronavigation. So we actually navigate either with ultrasound or with some modality, where should the craniotomy scar be. As compared to other parts of the body, surgery, you cannot operate supraradical resection. Not like a breast cancer, you operate a little bit margin. There is no concept of R0 in brain, because every single cell, even if you operate upon it, you cannot operate a normal tissue. Even if you operate a normal tissue like in frontal lobe, you do a lobectomy or a temporal lobectomy, you can never ever be sure because of the densely or deeply infiltrative nature of the illness that the glioma inherently is associated with. So it is very difficult to say R0 resection. Yet, neuronavigation or what's called intraoperative mapping, which is completely revolutionized. So you have to have an anesthetist and a neurophysiologist who puts electrodes in it and does that constant neuro mapping, which will help you in your surgery. The third thing is awake craniotomy. In all the functional tumors located near the functional area, especially on the left side allocated cortex, near the speech area, near the motor cortex. So what you do is you lightly give them anesthesia. There's complete profound analgesia, and then you ask the patients to do whatever they want to do. See the function. Either move the arms. Some people, there are this very elegant kind of videos of playing pianos and stuff like that. That's not so important. The important is that you can achieve very good resections these days because you monitor them very carefully. And so these are and there's lastly is the intraoperative MRI. So you have an operation theater where the instruments are actually MR compatible, and you have an MR, so you do an operation, even while local, you swing it back, you get an MRI done, go back, see and you fuse it on your preoperative image, make a volumetric extent of resection. If there is still a residual disease, you go back and operate. If you do not have all this, you must remember, whenever you become, I hope some of you become neuro-oncologists, make sure that the surgery, the MRI post-op is done within 24 to 48 hours after surgery, especially in gliomas. Because after that time, there's a significant amount of post-operative changes which will completely muddle the situation. You will not know how much is the residual and how much is the post-op change. But within 24 to 48 hours, it's fine. So, and as I said, there was this paper from MD Anderson a few years ago which showed that if you achieve more than 98% resection of the enhancing component of the glioblastoma, you achieve a survival advantage. The p-value became significant. But we were not thinking too much about T2-weighted flare abnormality, which is the lower grade component of the glioblastoma. It's like a tip of the iceberg. But now this paper came in, I think last year, which showed that if you achieve more than 53% of the T2 flare abnormality, also along with the malignant gliomas, you can actually achieve a better survival, which also comes to the fore how critical if there is one, maybe bone tumors, and I would say brain tumors are next, where you cannot diagnose only on a pathology. You have to have an MRI. You have to learn to read the MRIs, and not just the T1 and T1 contrast, but also MR spectroscopy. MR perfusion is a great, I have great fascination for MR perfusion, which I started in 2003, and then you have to have a joint neuro-oncology meet. So I started neuro-oncology meets in Tata in 2001. We used to do few cases every week. Now we do twice a week, about 20 cases per meeting for 2 to 3 hours. And I cannot tell you what an amazing experience it has been to review all the cases with the pathologist and the radiologist. And as I said, imaging is very important. I do want to make a mention on perfusion. Perfusion actually reflects angiogenesis. So contrast, when you see a contrast enhancement, it is breakdown of blood-brain barrier. Even trauma infection can cause that, or post-operation can. What you really need to see is at the capillary level. And what you do is, it's not an absolute value. You measure the perfusion. What you do actually is you push the contrast very fast within 120 seconds. And when the loss of contrast in a very angiogenic tumor, that loss of signal is captured on a dynamic susceptibility image. And then you correlate it with the opposite side and see the value, what's called relative cerebral blood volume per 100 grams of tissue. If it is more than 2 to 2.5, that means it is active tumor, and it will differentiate between a radiation necrosis or a pseudoprogression, as we can discuss again. Very quickly now, another lady, 34-year-old, was actually in Italy, was on a holiday from Chennai, by the way, and she fell down. And they found out there was a mass there, that what was a cyst, was operated upon the same night, not even an MRI, so I was amazed. So India is better that way. So it was after a week when the pathology came to the shop, it was an anaplastic astrocytoma. Came to me IDH mutant, so it was good. We went just for 15 to 20%. When I looked at the tumor, when I looked at the path, IDH was mutant, but ATRX was retained. It was bothering me. ATRX retained is either an oligodendroglial tumor or a glioblastoma. It is not a glioblastoma. So, but 1p19q came non-coordinated in NIMHANS as well as in Chennai. So I was just straddling what to do. We did a thin slice MRI. Here I think we did a thin slice, and we found out there was actually a residual tumor, which both here and in Italy was thought to be there is not much residual tumor. We convinced the family to get reoperated upon. She got reoperated upon, and lo and behold, 1p19q became co-deleted. Look at the enormous change in prognosis from a 1p19q non-correlated anaplastic astrocytoma with a median survival of 3.5 years to a 1p19q correlated anaplastic oligo with a median survival of only 15 years for this patient. So this is also important to remember in your practice, which also shows 1p19q was among the earliest pharmacogenomic studies in 1997-98 by Gregory Crancross, a neurosurgeon from Canada, but not in Toronto, in London, in Canada, and McDonald's. So they found out this classic molecular signature. It can be done with FISH. Unfortunately, there is no IHC. You have to do either with sequencing, RT-PCR can do too, but most of the people prefer FISH, including Never Center. And there are several large trials. One is an RTOG trial, there's a URTC trial, which compared radiation plus PCB chemotherapy versus radiation alone, and there was a significant survival advantage. You see this enormous classic JCO pictures, which shows the difference in survival between the two arms. But in low-grade gliomas, we were thinking whether we should add chemotherapy or not, because low-grade gliomas were not so much sensitive. That was in grade 3 tumor, which I showed you the median survival is 14.7 years. In anaplastic oligo, which are 1p19q correlated, or of course have to be IDH mutant too. So this was a RTOG 9802 study. 98 means when it started in 1998, that's how the RTOG says it. So it was in aggressive high-risk gliomas, which means more than 40. I personally believe low-grade gliomas do not exist after 40. Age, and second, if there was a significant residual disease. So they were randomized to radiation alone, which was the standard of care at that time, radiation plus 6 cycles of adjuvant PCB chemotherapy. Look at the survival, 7.8 years to 13.3 years. 10 years survival, 40 to 60 years. My friends, is there any site in solid cancers where you see 20% improvement in overall survival after 10 years with the addition of chemotherapy? That too, what we always thought was not a chemosensitive tumor of a low-grade glioma, not even in GBM. That is the power of adjuvant chemotherapy here in low-grade gliomas. Fantastic, 20% risk advantage of overall survival, and its benefit was obviously seen much more the patients in whom IDH1 was mutant. And we adopted this policy even before the trial was published in the New England Journal of Medicine, I think 2 years ago. We started in 2010 or 11, I think I started the protocol where we used to give what's called atypical histology. They were still called grade 2 in our joint neuro meetings. We used to call them 2.5. They were not quite grade 3, but not simple grade 2s as well, which has a little bit of mitosis, a little bit of atypia. And then we had our adverse clear abnormality. We used to give them temozolomide rather than PCV. We can discuss later whether we should give PCV or temozolomide. And this is not a randomized trial, of course. It's a single arm, phase 2 kind of a trial, but the 5-year survival was quite impressive. Very exciting. Can you detect IDH, what is called radiomics or radiogenomics? And there is an MR spectroscopy sequence, what is called 2-hydroxyglutamate, because the substrate of an IDH, when you metabolize it, eventually is 2,8-G, and that spectrum can be seen on MR spectroscopy. Very fascinating data. And lastly, which is personal favorite, is there's a vaccine being seen, and Mike Platten, who's a friend from Germany, who has been leading this initiative, where an IDH1 is better, but IDH is also a gluconeogenesis gene, as I said. If you can target it and make a vaccine against it, that's fantastic, and that may show some phase, and it's now, I believe it has entered a phase 2 design now. Diffuse midline glioma, what's also called brainstem glioma, has been one of the major problems ever since, and still is a major problem. And as you know, most of the brainstem gliomas more than are diffuse pontine. And now we know why don't they back. We have found out the mutation against it. It's like histone mutation, what's called H3K27, and there are 2 more mutations, H3.4.4 and H3F3A as well. So these, and we do not biopsy them, but now what's called time to rethink the unthinkable. We are now thinking of biopsying them because you can see it, we can see the profile of it, and then you can try to make a targeted therapy against it. But pediatric gliomas, this is just a case to show you, it looks like an oligodendroglioma, but when we see, it looked like a pilocytic astrocytoma. Now remember it, BRAF mutation everyone knows, right? Now BRAF mutation in brain, I just want to cut the chase. I just want you to remember one thing. If BRAF V600E is positive mutation, there are only 2 tumors, or well 3. One is ganglioglioma. It's a grade 2 tumor, kind of a low grade. 80% of gangliogliomas are V600E mutation positive. Pleomorphic xanthoastrocytoma, it's called PXA, again a common tumor in young adolescents. 70 to 80% are PX or V600E mutation positive. But only 10% of pilocytic astrocytoma, which is the commonest childhood tumor, is V600E mutation positive. But in pilocytic astrocytoma, what is important is called BRAF fusion, especially in that locus, KIAA154. So whenever you have BRAF fusion, it is unequivocal. It can be never any other tumor except pilocytic astrocytoma. So we introduced BRAF fusion, I think, 4 or 5 years ago in TMH. We get a lot of samples from all over the country because even NIMHANS does not have it as yet, but very likely many other centers will have it. And why it is critical? Because we can have BRAF inhibitors, as you know, against and try to avoid surgery or radiation in many of these young children. We actually carried out an analysis which was published, I think, recently, a couple of months ago. We tried to see what is the impact of 2016 on pleomorphic xanthoastrocytoma. Reis Tonse, who was my research fellow, he's actually now the proton research fellow in my center, actually carried out his study and showed that anaplastic PXA was worse. And I don't want to confuse you, there is also an entity called epithelioid glioblastoma. So we'll just quickly go to glioblastoma. Glioblastoma, this was the famous Stoops trial, which everyone knows. Standard of practice was radiation versus radiation plus temozolomide, and the 2-year survival was 27% versus 10%. And this is published, everyone knows about the Stoops trial. I kind of started the temozolomide in 2001 with Dr. Agwani that time, and we, even before the NEGM paper came, we started treating in 2002, carried out a meticulous prospective database, and has been published 4 or 5 times in the literature. Our 2 and 5-year survival is exactly the same as the Western, and 70% of the patients used a genetic brand. That's important too. We, as I said, 70% are genetic brands. We also try to see, we actually reported one case of an aplastic anemia because at the end of the day it's an alkylating agent, but we also try to see what are the potential toxicities. And in about 100 odd patients, we found out the female sex, and we have seen it many times, Overall, it's very well tolerated, but whenever you have a female patient, you need to be careful, especially in thrombocytopenia. And sometimes they can be, could be a, I don't know, there could be a polymorphism which has to be investigated upon. I also started kind of bevacizumab. We have now 230 patients, and we have treated few patients with nivolumab a few years ago as well. Very quickly, 47-year-old, looks like enhancing tumor, glioblastoma, MGMT was methylated, received treatment, kept under observation, did extremely well, 2009 to 2016. In 2016, had a recurrence, re-explored, glioblastoma, IDH mutant, MGMT methylated too. So you get this cohort of patients, even if glioblastoma is so bad, and we have about 30-40 patients in TMH who are now more than 5 to 10 years survivals, even if they have GBM and they have a favorable molecular profile. And short course radiation also with temozolomide can be given. Targeted therapies almost all failed, unfortunately. There was a great hope on EGFR vaccine. This was the only pharmaceutical trial I participated in. I don't generally do pharma trials. I do investigation trials. But what was impressive was that 80% of GBM had EGFR. It should work, right? It didn't work. Then we found out 15 to 20% had EGFR V3 mutation. And we found a vaccine against it. So it's really personalized. You have enriched biomarker. You have got everything, whatever you want, right? It's GBM. Large, and look at the phase 2 data. That's why I don't, phase 2 data, you have to be very careful. The failure of oncology progress is because we are not intellectually honest in phase 2. You don't need actually phase 3 trials, so many, if we were so good in our phase 2. Look at the phase 2 data. Never ever could one believe 50% overall survival at 2 years. Can you believe it? Never. So we thought, finally, even if there is 15% of the patients who have V3 mutation, we have a vaccine against it. Fantastic phase 2 data. We should do a phase 3 trial, right? 600 patients, I contributed 32 patients to this trial. Unfortunately, a negative trial. What does it mean? One, that we were not honest in phase 2, and 2, glioblastoma is really glioblastoma. We still just don't know what to do with this tumor. And this was very, very disappointing, as was Avastin. So 2 large randomized trials, as you know, RTOG 0825 trial and the Avaglio study done by the pharma company. Both of the trials completely negative. Selenchitide also, we participated, my colleague Tejpal Gupta's name is somewhere, not different. Although we still use, I have treated like 250 patients of Avastin, I give it routinely, and their quality of life definitely becomes better, but there's no clear-cut improvement in survival. And as I said, this was our experience as well. I will just skip it. There is some data on glioma stem cells. We have done some work on it as well. And there are a number of trials doing it. Finally, on CNS, the only point is CNS always was thought to be immune privileged. Whether actually it will, where will the T cells come from, right? So there is no lymphocytes there. But now there's a fair amount of data through the CSF, through the pericytes in the cribriform plate. They can actually go there. And there's a lot of data. DC vaccine largely failure. Rindopapivid, I just showed you the EGFR V3 vaccine was called rindopapivid. It's a negative study. A lot of data on checkpoint inhibitors. There is actually an NEGM, and again nivolumab, both in the recurrent setting as well as in an upfront setting is being investigated upon by BMS. There's actually a paper in NEGM as a case report 2 years ago, which showed that there was this tumor there was a recurrences in the spine. They operated upon it, made the chimeric antigen receptor, injected back into the cells, into the brain. There was a complete resolution not only of the primary tumor but also of the spine. And that is exciting. So there's a number of therapies going on it. Pediatric glioblastoma, because you see children as well sometimes, so it's not as common in adults, but there has been a lot of data actually from India. India has led the world actually in pediatric glioblastoma. People, especially from the group in All India Institute of Medical Sciences, in very prominent papers like Oncology, and the clinical data is actually ours from TMH, one of the largest study ever done of 66 children, but largely not so good. 5 minutes, I do want to talk on medulloblastoma because it is the commonest pediatric brain tumor. It's a grade 4 cancer. I usually tell my patients, look at the glioblastoma also grade 4, medulloblastoma also grade 4, 1% survival, here 70% survival. And not because of lack of effort, as you see. So these are called average risk is if the age is less than 3, metastasis, or a significant residual, more than 1.5 square centimeter, they are called high-risk medulloblastomas. But what has really revolutionized is that medulloblastoma is not one disease. Medulloblastoma is 4 distinct types of diseases. The one is called the Wind pathway, is the first one. Sonic hedgehog, which again is diverse to some extent, and what is called group, it used to be called C and D, now it is called group 3 and group 4. Group 3 and group 4 unfortunately have weak amplification, that's why they don't do so well, also have a very high proliferation index. And nuclear beta-catenin, if it is present, is a hallmark of Wind pathway. And the problem, and the thing is that if Wind pathway, even if it is a metastatic Wind pathway, the survival is almost 100%, 95 to 100%. Group 3 and group 4 very bad, group 3 especially. Even if it is a low risk disease, you have operated upon no metastasis. We were thinking that we will not get tissue in India, so we worked on RT-PCR based. We identified a set of 9 coding genes and a set of microRNAs because it is easy to do on paraffin blocks. We compared with, this is a very fascinating data actually. When we tried to do it, our German colleagues and our other people in the world did not believe us. Most of the times when we do collaboration, we send the blocks abroad, right, for them to do it. It was a rare case actually, they sent us the block. The German people sent 42 blocks. We compared it, except one patient we got it right with our technique, and next day the paper was published. So what it means now is that every single medulloblastoma that you see in your practice, don't treat it until you do molecular profiling. Remember it. Do not treat it, because it will completely change it. And there's a lot of data, a lot of studies coming on depending upon the different profiles. Sonic hedgehog is the only medulloblastoma which actually can metastasize, especially in older patients, can be seen in pediatrics, infants and older people. And there are what's called smoothen inhibitors, can work. I've been hearing for the last 10 years actually, but nothing has come out, unfortunately. And we are realizing that, unfortunately, the ones that you need in children, they have other mutations, like SUFU mutation, there are GLI2 mutation, which actually makes the work much worse. And it can probably work in adult where you don't need it, in fact, so it's a kind of a difficult situation. It was actually a case report in NEG a few years ago. We also did a study which is just in press, you don't need to know it, but very briefly, on 130 patients, we just used to put MRIs in our joint neuro meeting in a blinded fashion. We used to tell what is the, just on an MRI, it's called radiogenomic. And we found out 2/3 of the patients we got it right. Archo was our student that time, he's in Toronto now. Sonic hedgehog, 95% of the times if you show me the MRI, we can tell you it is sonic hedgehog, even without pathology. And group 4, 75%. The Wind tumors were the ones which were difficult, and we have done a nomogram on it. So lastly, in medulloblastoma, in Wind pathways especially, not only the escalation, there is also a de-escalation because they have survivorship issues. So they are reducing the craniospinal dose, which used to be 23.4 Gray plus boost plus factor regimen, as you know, using vincristine, carboplatin, or alternatively CCNU. They are reducing dose from 23.4 to 15 to 18 Gray. We almost have given up vincristine during CSI, doesn't work. We always wonder whether it actually crosses the blood-brain barrier. By the way, for PCV also, we don't give vincristine anymore. We only give CCNU, and sometimes we give procarbazine, which we can discuss. But in TMH, what we have done, I led the study, and now I'm not there, but my colleagues are doing, which is revolutionary. No CSI, only local tumor PET. So imagine there is no craniospinal axis, radiation, so supratemporal part of the brain, no spine, so how better the patient would be because you reduce the side effects of radiation. And we give chemotherapy, what's called for Wind trial. We have very strict stoppage rule, took us a year to get the IRB approval. And if it does come positive, it could be a potentially practice-changing trial. And you must try to, if you want to know more about medulloblastoma, go to Neurology India last year. Every single aspect of surgery, radiation, chemotherapy protocols, pathology, MRI, everything is in this manuscript. So you can read what should be the ISLO guidelines on medulloblastoma. It's been adopted in many parts of the world, including in Africa and Latin America. That comes to the point, what is called survival and survivorship, and survivorship is very close to my heart. That many patients do survive, especially childhood brain tumors, but they suffer from neurocoagulation, very important. We did very early in 2001, I started this prospective study of neurocognitive with a relatively simple battery. We found out many patients actually before you start adjuvant therapy had poor IQ because of tumor and surgery, not only because of radiation. And also, how do you generate evidence for radiotherapy? Now protons are coming, right? So unlike pharma, we don't do randomized trials so much because very difficult to do. But we did one randomized trial using a conventional radiotherapy compared to stereotactic conformal radiotherapy, which is a very high precision radiation, and chose a primary endpoint, which is very important on the clinical trials. You should spend time and again on the endpoint. So we chose the endpoint of neuropsychological, cognitive, endocrine, and neurological function, and had to accrue 200 odd patients to have the appropriate statistical power to show in a phase 3 randomized genetic level 1 evidence, which doesn't exist in radiation, unfortunately. But fortunately, we did it. It was presented in ASCO and SNO 2-3 years ago, and found out that all the parameters of full-scale IQ, memory IQ, depression, visual motor organization, endocrine was significantly superior in the conformal arm as compared to the conventional arm. And the new endocrine dysfunction was also significantly better. There were not too many endocrine dysfunctions because of the dose to the pituitary hypothalamic evidence, and was published last year in JAMA Oncology, one of the few papers which has provided level 1 evidence for high precision radiation and more than 80 to 90% survival in both the arms, and has been lauded in many parts of the world. Finally, second cancers, growing and valid concern in long-term survivors. And protons, actually, if there is one thing which protons can reduce, it is the dose to the surrounding structures, and the second cancer risk is relatively less. And as you know, there is a relatively low dose and there is virtually no exit dose. It just goes and just drops. There is no dose to the rest. So you can imagine how much reduction of the normal tissue will be there. We also found out for the first time in the world the association of radiation dose to the left temporal lobe and also to the role of hippocampus. Adolescents and young adults, increasing thing. There's actually a conference in Chennai in September on it, and this is very important. We just published demographic profile of more than 1,800 patients in this population. And finally, the tackling illness, quality of life, patient-reported outcomes, so important. And in brain tumors, even more important. And we published this paper many years ago, one of the largest studies on quality of life in brain tumors. And we did the translations and stuff. But what I want to tell you is that poor socioeconomic status, literacy, older age, and malignant tumors had poor quality of life. This was very interesting. We compared with the URTC trial of Rogers 2, that one was the quality of life person. We found out all the domains, the Indian data was worse as compared to the European data, except in 2, drowsiness, because our patients were younger, so less drowsiness, and future uncertainty, because we don't talk to the patients, right? So this was quite interesting. We also carried out a survey on palliative care, and there was again major issues. And that led me to start the Brain Tumor Foundation of India in 2000s, 18-year-old now. And we do a number of programs on it. I do a monthly support group, annual art festival. 2 of our paintings had actually come on the cover page of Oncology a few years ago. 80 to 90% compliance to therapy over a period of time. But more importantly, and most importantly, 30% of our patients are in prospective clinical trials. And they are all investigator-initiated, and compliance is more than 90%. Any patient, including in your practice, wherever you work, talk to your teachers, they want molecular markers, BRAF, metroplasma, IDH, 1P19Q, just send the block to us. We'll do free of charge. One of the things I want to finish was the growth hormone. You see these children in survivorship clinics, they are cured. Craniotomies, medullos, gliomas, but they are shot. And it's such a painful thing. And no other government, and you know how expensive it is? 25 to 35,000 per month, and you have to give it continuously till they achieve puberty, right? And we couldn't do anything. So, but we eventually did. We have now spent 3.5 crores on 82 children who come to the clinic every Wednesday, every month, or every 3 months now because of depot availability, and that helps. And we also ran a project on disseminating brain tumor information in different languages. In all the 22, the dream is 22 national languages, 9 we have managed, 14 more to go. And finally, I think is you must try to, if you are interested in neuro-oncology, join Indian Society of Neuro-Oncology. Every year we have a meeting in March, and there are several fellowships available. If your abstract is accepted nationally and internationally, you can avail for that. And also in our practice, it is always a dilemma. Should we just take care of the family and patients, or should we clinical trials? In our country, it's a big dilemma. And I have written many years ago in Lancet that we must do clinical trials. And actually last month, 2 months ago, we showed how you should do it. And I also argued a few years ago, the problem is why the progress, it seems there's a lot of progress, but actually the progress is not so much in oncology in general. And one of the reasons is we think that 2 to 3% improvement in overall survival is the outer level of our intellectual expectation. We don't think big. And immunotherapy may show this, and that's what I have argued. And I welcome all you at some point of time to visit our cancer center, which will start in August, and the proton therapy will start. Every patient will be seen what is called cancer management teams. There will be 9 such teams, pediatrics and young adults as well, and will be strong emphasis on prospective data generation. And hopefully every single patient will be on some clinical trial to get us some idea as to what we are doing in patients. I thank you for your attention. Sorry I exceeded by several minutes, but I thought it was a good opportunity.
Yes. Any queries to sir? I think that, yeah, please.
The WHO classification on, I think those neurological tumors had just come out there. So you really simplified it. My question to you is about this extended duration of temozolomide, adjuvant temozolomide in GBM. There are 2, again they're very small, but they're retrospective, but they seem to look excellent at 6 versus 12 months.
Sure. So if you talk to Roger Stroop, and he's a very dear friend of mine, so we have spoken many times, he says, what is the evidence for giving more than 6? So he truly believes it should be 6 cycles only. What we do is we took a pragmatic approach in TMH. What we do, if they are MGMT methylated, we definitely give them a year. If they are methylated. If they are unmethylated and do not have any significant residual disease after 6 months, we just don't give them anymore. However, if there is a residual tumor, especially on the flare abnormality or T2, and it continues to regress either anatomically or biologically on perfusion after the 6 cycles, then we give them 12 cycles. Lastly, in patients with gliomatosis or grade 2 tumors but with extensive disease, we actually give for 24 months, 2 years, because there is continuous decrease, although it's still not GBM. Now you see temozolomide has to be given virtually in every tumor, in oligos, in grade 3s and grade 2s as well, based on the large trials. So this is a kind of a pragmatic approach that you can adopt into practice. Any other questions? Yes. So PCV, as I said, it started with procarbazine, CCNU, and CCNU, right? Vincristine, CCNU, and procarbazine. The origin was by Vic Levin from MD Anderson many years ago, and is a relatively intense protocol. You give day 1, day 8, then you wait for 3 weeks again. But we mostly adopt what is called MRC protocol, which is the Medical Research Council in the UK, which is very simple to do. You just give CCNU day 1, 100 milligram per meter square, and typically the dose is between 160 to 200 milligrams, and it comes in 40 milligram capsules. It's very emetic, so you have to do the proper precautions and anti-emetic prophylaxis. And then you start procarbazine the same day, again 100 milligram per meter square, and typically you give 50 milligram TDS or 50 milligram QDS for 14 days. And then you repeat same after 6 weeks from day 1. So it's very simple, so you don't have to call the patients again and again. Many a times these patients are pre-treated heavily with temozolomide, sometimes 6 months, a year. You may not be able to do procarbazine for 14 days, and then we reduce the dose to 10 days, which is acceptable. But CCNU, which is the nitrosourea, is the main drug that you should try not to compromise. The major toxicity, dose-limiting toxicity, is thrombocytopenia and in general WBC count as well. You have to be a little bit careful, but particularly platelets. And most of the people, especially with the RTOG 9002 study, they just give you only CCNU. And then I couldn't show you everything. There's also a very nice protocol, which also I adopted recurrent gliomas. So if they are grade 2, grade 3, treated the radiation temozolomide, after a few years become GBM, treated again Rakesh, maybe MGMT methylated or IDH mutant, which means they will respond to nitrosoureas. I give them Avastin plus CCA. So Avastin is 10 milligram per meter square, as you know, every 2 weeks. So you give them every 2 weeks Avastin. So you give 3 cycles. On the 3rd cycle, you give them CCA. If they are MGMT methylated and it's a long DFI, especially in transformed gliomas. Sometimes can be given in GBM as well, because you cannot give temozolomide. Temozolomide alone should try to be avoided. There's very elegant data published in Science by Joe Costello in UCSF, and it's been adopted in all parts of the world now. If you give temozolomide alone without radiation, which used to be given sometimes, it can cause a hypermutation syndrome. It causes tremendous amount of mutations, which makes it resistant to further radiation and further cytotoxic chemotherapy. So most of the people are avoiding temozolomide now as a monotherapy. And you can combine with other treatments. And also, as I said, if you want to use indicated setting bevacizumab, then you could either combine with temozolomide, give it alone, or give it with CCNU. Although the classic protocol is to use with irinotecan, where the dose is 125 milligram per meter square. If you're using a non-enzyme inducing anticonvulsant, which you should. Levetiracetam is the non-enzyme. We'll have some other session.
Thank you so much, sir. As medical oncologists, we have 1/10 of the number of investigator-initiated trials that you have started. We should be very proud of ourselves. So, thank you.